Okay, I'm going to move away a little bit from the theoretical portion of the course to a little more of the practical portion, is how to report the data that you're going to get from these prediction models. This is going in and out. Is it still okay? Okay. So I'm going to talk a little bit about the tripod statement that you all saw in some of the materials that we hand out before. And for this, we're going to talk about some of the basics of good reporting for prediction models, why you need to, what's the importance of good reporting. Then we're going to review some of the more important elements of the tripod statement. And then we're going to break from talking and lecturing, and we'll have a group discussion. You're going to break into small groups, and you're going to talk about a paper that we've picked. And then we're going to look at the findings that from what you found out in the paper, how well you rated it as far as the tripod statement goes. So I guess the question is, why is good reporting so important for prediction modelings? And you got to think about who your audience is for the prediction model. It's going to be a clinician who's sitting in his office with a patient in front of him, and the patient asks him that question, like Peter was talking about. And you want to be able to say, as the clinician, what is this patient's risk of some event that he's concerned about? So to do that, the clinician has to understand sort of how the model was built, how good the model works, and whether he can trust the model to give a prediction to his patient. One of the things that you want to look at, one of the clinicians want to look at, is whether it's applicable to their patients. If it's a patient who's working with all people over 80, and the model was built with a wide variety of ages or even younger ages, that may not be applicable to them. The other thing you want to look at is, the clinician would look at, is whether the data that was used to build the model and is used to inform the model is available to them. How useful is it? Is it a clinical decision that's important to the clinician? For instance, stroke for patients with atrial fibrillation is a big deal. And can the model be trusted? And we'll talk a little bit about what builds trust in a model. You want to look at whether a model is reliable or not. So these are some of the parameters that we talked about before in discrimination or in calibration. Does the model give them a performance that is acceptable to them for them to sit back and say, yes, I can give my patient a decision with a high degree of confidence. And whether the limits of the model are understood. So if a model was built in all older people, that might not be the model that you use if you're working in pediatrics. You want to look at reproducibility of the model, whether the model was tested sufficiently internally and externally to see whether it spans a wide range of different data sets, or whether it was built on a very, very local data set and it may not apply to a wider audience. The important thing that you find here is that in the literature, most model reporting is not done this way. There's not enough evidence out there in the reporting of these models for the clinician to make these decisions. I'm sorry, did you have a question? No. So we get to the tripod statement, and the tripod statement is a framework for reporting on prediction modeling. It's similar to STROBE. I don't know if you've seen STROBE for observational data sets to be able to improve the reporting for observational and give good reporting for observational data sets. So tripod was built from a committee of 25 plus members who are experts in the field of prediction modeling. They started out with over 75 possible inclusion parameters that you'd want to include into the reporting, and they winnowed that down to about 22, which you see in your handouts. I'm going to go through a few of them And we'll talk about some of the importance of each of these. And for each of them, I have what's important about it, and give an example of a good example of that section of the paper. So very simple, the title, and it provides a concise summary of the model. So one of the things you want to look at, let me see if I can, oops. One of the things you want to look at is, does it say what kind of model it is? A development, is it a development model? Somebody's developing a model, or is somebody taking a model from somebody else and validating it on another data set? What is the model doing? In this case, it's estimating the probability of coronary artery disease in men and women. So that gives the person, the clinician, right away, is this something that's important to me? Coronary artery disease, yeah, I'm a cardiologist. Wait a second, okay, I'm going to look at this. And who is it in? Men and women with suspected coronary artery disease. So this would be, like I said, diagnostic model to see whether this person has coronary artery disease. In the backgrounds and objectives, you want to look at why the model was developed in the first place. What was the important reason for developing the model? And so an example of that, the model was used to develop and validate a clinical prediction rule. So it tells you exactly what the purpose of the model was. Develop the prediction rule in what set of patients, women presenting with breast symptoms, and why was it developed? To provide more evidence for gynecologists to refer this woman to an oncologist. That's the sort of audience that they're looking for in this. For the methods and the data source, now this gets to whether the clinician will be able to trust the data. Was the model built with enough people? Was it built with a reliable data set? So in this case, in the example, it was built from the Framingham Heart Study. So clinicians might be very familiar and very comfortable with the data from Framingham Heart. In 2,500 to nearly 3,000, 2,500 men, 3,000 women, ages 30 to 74. So that gives the clinician a very good idea. So it's not information for pediatrics, and it may not be information for somebody who treats the very old. And you want to know, what were the exclusion criteria? In this case, persons with overt coronary heart disease at baseline were excluded. So that gives the clinician an idea of who's in the model, who's not in the model, and whether it applies to their patients. Then you want to thoroughly define the outcome, so the clinician knows, exactly what are you talking about that you're predicting from this model. In this case, you're talking about incident diagnoses of breast cancer, and goes back to, once again, how the data was collected and the validity of the data. In this case, it's from a self-report, which may give some people pause that it's all self-reported data, but there is something in there that says that 93% of them were confirmed by a medical record sometime after that. So that gives the clinician some more confidence in the validity of the data. Is that no? Just stretching back there? Okay. The predictors. You want to let the clinician know what the predictors were in the model. So in this case, they're looking at a lot of liver tests. And because this would be something involving liver failure, and you want to know when the data was collected for this. In this case, it states clearly that all laboratory tests were performed within 90 days before the liver biopsy. Which statistics did you use to develop your model? So you want to clearly define for the clinician exactly how it was done. So in this case, they used Cox proportional hazards to develop the model. That was the regression model that they used to develop it. and how are they going to analyze the data to see whether it was, there was a level of validity to it. So in this case, they talk about examining calibration discrimination, like Peter talked about. We talked about doing a calibration curve, and also looking at the receiver operator characteristic curve. Model specs. So these are in the results. You want to say, what did you get out of the model? So in a lot of the framework that we have the capability to output the full model specification. So there's no guessing on what's in the model and what's not in the model. In this case, they used a table with, they talked about all the parameters that were in the model. In this case, it was a small model. You know, in here, they gave the betas and standard errors and p-values. That's not something that we're particularly looking for. You know, as Peter said, you know, once you build the model, especially in a large-scale database, those values are not the real values. You know, it's going to give a false idea of what the risk is if they start thinking about betas as being related to risk. And then you want to look at the performance of the model. And this graph shows some of the things that you would want to report in the model, such as the calibration curve and the ROC curve. So those, at least as a minimum, should be things that you should be reporting within the model. Okay, so now what we're going to do is we're going to take a very famous paper. Most of you have probably heard of CHADS-2. It's a way of predicting stroke risk in patients with atrial fibrillation. And what we're going to do is we're going to go through the paper, which you have here, and I have some more copies here. We're going to break into groups. And we're going to go through the 22 elements of tripod, and you guys are going to rate them as far as A. You know, give it a rating of A if it completely fulfills the requirement. Give it a rating of C if it sort of fills the requirement, and an F if they skipped it completely. It says about 20 minutes. I think we're going to give about 30 minutes for this. So I may have jumped the gun a little bit. So I talked about CHADS-2, and I'm kind of familiar with it. Is anybody else familiar with CHADS-2? Let's see if a show of hands. Any clinicians out there? Any cardiologists in the group? Yeah. Say what?
I'm at the National Heart, Lung, and Blood Institute. My field is epidemiology.
That's not. I don't think that's on.
I know Brian Gage. But
Oh, okay.
Familiar, but yeah.
So actually, so you've beat me as an expert on this. If you can talk a little bit, does anybody want to talk a little bit about how CHADS-2 is used in clinical practice?
As a clinician, every time I see
folks,
atrial fibrillation patients, we should calculate the score in CHADS because we should decide whether we should use warfarin or another anticoagulation in these population with atrial fibrillation. So it's very important, and we always calculate these scores in every patient with atrial fibrillation.
And just curious, what's the cut point that you normally use? If somebody's above, what do you say they should go on warfarin or anticoagulant?
If he or she has the more than 2 scores in these scoring system, he or she has to have anticoagulation.
More than?
More than 2.
More than 2, yeah.
2
so
or than more.
Yeah, so that's the cut point. So it goes up to 6, but you're looking at 2 and above is what they're using for treatment.
What's the range of the CHADS score?
0 to 6, yeah. And one of the things that clinicians like about it, and this is where some of our models are going to differ, is you can do it on one hand. And especially if you're counting up to 2, you can do it on 2 fingers. Did you have, and you'll see in the papers or the papers you've read, do they have congestive heart failure? Did they have hypertension? Or are they over 65? Those type of things. And versus our models, which are going to be much more complex than that. Yeah.
I was just going to say, with some of these tools available in a mobile app, physicians will still be able to do this just in one hand.
That's exactly, well, very good. There you go. And that's exactly right. You know, and somebody was talking about payers, you know, getting involved. And, you know, if they, you know, what I always think about is, you know, if the data is already there for payers and the clinician's sitting there with the patient and they know the patient is with United Healthcare or Aetna, you know, can they provide, can they, you know, go into the data network that they have and get the information that they need to be able to fill the model, inform the model, and see what kind of risk score they actually get from it.
So Simon was making the point that in clinical practice, you are using this patient-level prediction model for every patient to make a treatment choice for every patient.
That's right.
Where in my hat on the pharma development side, I work at a company who has developed a new anticoagulant, and we spent over $1 billion doing clinical trials, and every clinical trial was based on finding patients based on this CHADS-2 score. So this thing is the foundation of clinical development, it's the foundation of clinical care, it's the foundation of practice for patients with atrial fibrillation.
Right.
So this is not just some rando paper.
So is this score, is there like a dashboard that it gets used in, or? So I'm just wondering how it gets implemented, like
We
is it a
just
table?
remember how to calculate it because it's a very simple scoring system. We don't need any dashboard. We just remember and calculate every time.
And the reason why it's so widely used is atrial fibrillation. There's a relatively high incidence of it, but the outcome is bad. Nobody wants stroke. That's one of the bad ones that people don't want. Okay, so what we're going to do now is we have everything handed out. So I'm going to you guys are going to go through the gauge paper and then go through the scoring sheet here and give it an A, C, or F, depending upon how you feel they fulfilled the requirements. All right, so let's go through these point by point. Okay, we'll start with the title. Number 1. What grade did you give it? There's no B.
We
A.
decided we needed better gradation.
Oh, you needed better gradations? You want to handle a B?
We can handle it.
Handle a B. Okay. Number 2, abstract.
B again.
B again. Okay.
D or B?
B. 3A.
A.
A. Okay. 3B.
Am I representing the whole? Everyone?
So if any, yeah, we can give multiple, right? Your advanced spreadsheet can handle multiple. Yeah. 3B.
A.
A. Okay.
A goes on till then A.
Okay. Well, we'll come. Okay. So 4A. 4A. We get a C. 4B. F. 5A. C. 5B. A, D. Where are we going with D? D? C, D? C. We'll give it a C.
What? I'm sorry, what was it?
5B. 5B, that was right. That was a C.
So can you just read the question so I can keep track and so we can hear what
Okay.
answer the numbers? What is the thing we're asking about?
Okay, 5C. Given details of treatments received, if relevant. Did we get a 5C score? C. 6A. Clear to define the outcome. C. 6B. Report any actions to blind. 6B. No mention of that?
I didn't see any mention of any
Yeah,
blinding.
not applicable, or did we put that in there?
Not A. That's fine.
Okay. 7A, clearly define all the predictors. Nobody got to that? A. Clearly define the predictors, give me A. 7B.
Oh,
Oh, no, wait.
So you think? Oh, I'm sorry. What was the one we just gave an A to?
7A.
that was too generous. It didn't. I would actually probably say C.
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 It told you what they were, but not necessarily well defined so that you could repeat it.
Yeah.
7B, blinding assessment, outcome assessment. Did they do any blinding there? They talk about that?
I didn't see that.
Okay. They talk about missing data at all? Oh, I'm sorry, sample size, number 8.
Looked like it was largely just availability.
Availability.
Like that was the number of patients in their cohort that had AFib. So I guess it was. You can infer it.
Okay.
B.
B. Missing data, number 9. How was missing data handled? C. Okay. 10A. How are the predictors handling the analyses? Oh, we're still over here. 10A. How are the predictors handling the analyses? A. Gave it an A. 10B, specify type of model building procedures. A. 10C, for validation.
What was? You said A. So what was their model building procedure?
We didn't say we agreed with their model building procedures, but they told us how they did it.
Okay.
It was just a score. I'm sorry. So they just
that
built a
was
score.
that was the final model. How did they get to the model? What was their model building procedure? How did they arrive at that 6-point scale?
Well, it was kind of empirical in nature. They just kind of picked the predictors, did I misunderstand?
I think if my understanding of reading Tripod for this one specifically, it's not what was the final model, which I think in this table you can see how to get to the 6-point score. It's how did they arrive at getting to that model? So for example, did they run a logistic regression with 100 variables and then magically these 4 integers popped out the end? Presumably not. They probably ran a regression. I'm pretty sure that if they ran a regression, though, the beta coefficients weren't integer-based numbers. So did they get like rounded numbers, or did they just round up the numbers? How did they come up with it? Or did they just basically say, you know what, I bet you I can create a bunch of integers and add them up and get something magic?
I think it was a clinical gestalt about what they thought it was relevant, but they didn't specify. They didn't start from a model.
Right.
Okay. So how would you think about, so do you based on reading the paper, the model building procedure? F, okay.
A little different.
Right. Sorry, we're switching your A to an F. It's just for the record in terms of, we're really talking about preference. It's not so much about whether it's right or wrong to use clinical expertise or to use a model, but it should be clear how you got to that, as opposed to simply just asserting, here's magically a model.
Right. So the point is, can you repeat their study? Can you test it on your set of patients based upon what they said within their article? So think about it from that perspective. They got the. But like Patrick was saying, why did they get 1 point for each one?
Yeah, so they did make reference to 2 prior schemas that at least suggested why they were motivated by those types of variables. But when you take so that's good. That's some of that clinical gestalt, some prior experience. But how did they take reading 2 PDF documents and then translate that into, I'm going to create a numerical scale?
Based on past literature, because the relative risk was double based on these 5 papers they cited, 2, 4, 5, 23.
So there's some references of things that they think potentially are in some way possibly relative risks, kind of.
Hand wave, double the risk.
Double the,
Yeah,
okay.
that's right.
And since you all listened to Peter this morning talking about the difference between explanatory variables and a predictive model, we could just wonder about that. All right.
Okay, 10C. For validation, they claim this is a validation study. Describe how the predictors were calculated. F. Okay. 10D, specify all measures used to assess model performance. I hear an F and a.
They just made a table where it says, look, the scores, the higher scores have higher risk. I mean, that's not a performance.
Right.
I mean, it's a D minus, minus, minus.
Okay. 10D, specify all measures used to assess the model performance. No, we did that one. 10E, describe any model updating, recalibration. Did they? They didn't. Okay, risk groups. Did they stratify by risk groups? Any risk groups did they talk about? What were the risk groups that they provided?
Jenna.
Remember,
They did A.
in the method of data-specific scores, they just
Well, those are the predictors, right?
Oh, I see.
There was something about aspirin in there.
Yes.
It wasn't quite clear exactly what they were talking about.
Oh, that's right.
I'm not sure.
Yeah, so I would give that a.
What are we saying? How well do they do with risk groups?
Well, they talked. Any
Wojciech,
Christian?
you're saying what?
Christian's good for an F.
Wojciech confirms the F. Just like an aspirin discussion, very briefly.
Okay, 12. For validation, identify differences from the development data in setting eligibility, criteria, and outcomes. How did they do this validation? Have we moved? Okay, so we didn't quite get to that one yet. That's how they measured it. So one of the things that, so they were talking about validation studies, and the title of this is validation of. So what were they actually doing in this? They had really 3 models that they were testing. 2 of them were sort of tested before. One of them is brand new. So if you're creating a new model and you're testing it on one set of data, that's not really validation. That's more development. So they're sort of doing a development validation, something to keep in mind as you start looking at how to do that. Okay. Now we're up to 13A. The flow of participants through the system. Yeah. C. Okay.
It's not that bad, but there's no diagram. It's a little confusing, but it's okay.
13B. Describe the character.
The mics from there.
Okay. Okay, there you go. That's going to be easier. 13B. Characteristics of the participants.
Also C, there is basic demographics as a table 1. There's not much about missing data. All they're saying is if they bumped into missing data during chart review, then they added them. So,
Okay.
which it's in contradiction to my question in the morning, which I was not allowed to further pursue, that TU0 is T0, and you can't add,
Data afterwards.
predictors after that. So they did that.
13C. For validation, show comparison with development data.
F.
F. 14A. Specify number of participants and outcome events in each analysis.
A.
A.
They did.
14B. Unadjusted association between candidate predictor and outcome.
F.
Yeah.
Didn't even come up.
15A. Full prediction model to allow for predictions for individuals.
Well,
Yeah.
So you're saying C. So just, where was the model provided in this paper?
It's F.
Where specifically can you find the model? I want you to all look at the paper. It is there. Where is it? So there's some free text that kind of qualitatively describes how you might contrive a coin. And then in the footnote of table 2, it says how the score is actually computed with 1 point and then 2 points. So you'd think if you are going to write a seminal paper about a prediction model that you expect to be used in clinical practice for every single patient around the world, that maybe you'd have something a little more prominent than the size 7 font.
Okay. So what were we up to?
15B.
15B. Explain how to use the model.
What's that? F?
Okay.
F.
16. Report performance measures with confidence intervals.
No cutoffs.
Performance measures with confidence intervals. We did
A.
A.
Get some grade inflation back here, which will hit too. We time adjusted it too for 2001.
Oh, okay. 17, model updating.
Not applicable.
What the
Change the
results of the
model.
model. Did they change the model? Did they experiment? Change the specification after they did it? Yeah.
Can I go back to the model performance? I thought this would be the discrimination and calibration.
The two curves, the area under the curve, and I don't see any of that in the paper.
So VoiceX challenging the A for performance measure. So what do you all think about that?
Which one number is that?
16. So how did they report performance of the model?
No, it's an F. All they do is higher score and higher risk.
They only reported the like descriptive statistics, which score had the level of raw rate of stroke and adjusted rate of stroke, but the model should have said you will have stroke and it's what's the discrimination and exactly what was said in the morning.
It had C statistics in it. We've got C statistics with confidence intervals. So make that B.
So they have the C statistic is the area under the ROC curve. So at least a measure of discrimination is provided with a confidence interval on that. So they didn't give the ROC plot, but they at least gave you the AUC value. So that's something.
And
you
nicely tried to prepare those confidence intervals that they won't overlap, which you can't do.
Yes.
So
So what's your grade, Nicole? C plus. Okay.
So as far as calibration goes, they didn't do the calibration. They showed the table, but they didn't say how well their model predicted it. You know, it's like, you know, it could be a calibration curve that's way skewed. They're way off one. What are we up to? 17. 16 we did? 17. 17. Model updating we said was an NA. Limitations. They talk about limitations of the model, number 18. Okay. Give them an A. 19A, interpretation.
Which one are we on?
19, that was 19A. 19B, give an overall interpretation of the results. Considering objectives, limitations, how well did they do on that? See? Okay. Implications of the model, number 20. Discuss the potential clinical use. F.
How could that be? It's used in clinical practice every day for every patient with AFib.
All right, so we have. So we're. Where do you, very end it says,
Last two paragraphs, they say the clinical significance, statistical significance was something we felt did an okay job in 2001 of addressing that.
oh, okay.
Okay, so maybe I'll model average the A and
C.
the F to a C.
Okay. 21, supplementary information. So supplementary information. So somewhere they provided the full model. They talked about how they built their cohorts. They talked about how they did all their, that's all in the F, okay. And funding source. Okay.
In 2001, was a web calculator common? I'm just asking.
Oh.
whether
Yeah, it's not really
was an
applicable.
applicable question at the time.
Oh, yeah.
That's
Well,
part
that
of
was
it.
just part of it, the web calculator. But still, if supplemental information, you could provide the full model. You could provide, exactly how the cohorts are built.
Actually, we are not using chess for clinically. Actually, currently we are not using this score because we are using updated version of data version of chess score, which called chat basis.
Chance VASP 2, yeah.
It's more complex score system, but we can calculate. I can calculate it by my brain.
That's right. So we have a final verdict.
There's your report card that you guys gave this class. Greens are A's, yellows are C's, and reds are F's.
But I was commenting earlier that it's unfair because paper came before the grading criteria. It would be interesting. If I want to learn, I would almost learn from the best paper which combined with it the best way. And that way I would learn. But I appreciate that this is still kind of used a lot.
Yes, but you're raising a good point, Wojciech. So it's a little bit unfair because maybe these authors, had the tripod existed, maybe they would have followed those. The challenge that I would put to all of you is this is not a hypothetical. We didn't just like cherry pick a crappy paper for no reason. This is a predictive model used in practice every single day. And this hasn't gotten better. This is still the paper. There have been subsequent papers. One thing that's highlighted, what was the AUC that this paper reported? See specific, what was the value? 0.8 for CHADS2, it was 0.82. So this analysis of their data set got an AUC of 0.82, and that sounds generally kind of encouraging on this data set. However, there's not any external validation provided to see does that actually hold up if we apply it to other data sets. What we're not sharing with you, but you can go look in the literature yourself, lots of other people then said, wow, if we're going to use this for clinical practice, I guess we should check to see how well it works. And there's in fact even a systematic meta-analysis of all of the subsequent external analyses, and they show that the AUC of this thing outside of this paper gets somewhere of an AUC of about 0.65. Okay? So this model is only marginally better than random guessing, and it is the current model driving clinical practice every day.
Of course, but if they apply it successfully, is there a way to measure the success of these practices and see if they're using the system showing the positive difference or not?
Well, you know, if we were taking a class called financial level prediction, and our goal was to make money on Wall Street, an AUC of 0.51 would make us all billionaires, because you'd only need to be a little bit better than random guessing to win everything. But the difference that between us being a quant on Wall Street and being in healthcare is when we get something wrong, it is not just that we lost a couple dollars. When we get something wrong, we're negatively impacting a patient's life. So 0.65 is a lot better than if doctors are randomly making guesses of what to do for patients. I'm pretty sure that doctors are a lot smarter than doing random guessing for what to do with patients. However, what we have an opportunity to do is if we could get a prediction model that actually performed well and could be validated, then actually we could actually do something quite important in driving decisions based on this data.
that statistic using either the bootstrapping random Monte Carlo simulation to get that estimate, as opposed to using the test train paradigm, this cross-validation. Had they used the test train paradigm, or cross-validation paradigm, would you not have seen their performance go a lot lower? And it's because they're reporting this bootstrapping that you're having this inflation. Like, it could have done better just on that existing frame if it had gone with the other paradigm. They didn't. Is that an accurate statement? I'm not.
Jenna, you're going to get into at least the cross-validations are you take within the framework. I mean, I think in this paper, it's not, at least in my opinion, it's not actually really clear what they did to do this validation. So, for example, at a minimum, I would have liked to have seen a very clean train test split, but because this is a validation, they kind of just had this score magically applied to a data set and reported out the results. You could imagine that if, given that they were going to just contrive a score, it would have been nice for them to have maybe multiple cuts of the data just even see, or apply some sort of cross-validation. I'm not sure that would have changed things, because there's so many other variables at play of things that could have gone wrong.
But wait. They didn't derive, didn't we work this out? They didn't derive the CHAT score by doing the training validation. They pulled it out of their sleeve. And so you don't have you can't test it on the whole data set, because the training was anything the data set that the doctor saw in the previous life somehow mushed through the neural network and came up with the predictor.
Yes, you could, though, for example, if you had a data set, you could split your data set into partitions and see how well it worked in random subsets. In the case of the fact that they provide a conference interval, that's just based off of an assumption about how that performance works. But yes, I mean, what you're going to learn about for the rest of the day is like, how could we potentially, let's just start with just saying, do it differently.
But I mean, Patrick, there's one thing we are missing out. And we're saying, look how bad this thing is. The good thing about this is any garden variety doctor in the middle of Kansas can create a score within a minute. While if we, of course, let loose all the machinery, artillery that Jenna has, then that's, of course, impossible to do by hand. So somehow we probably need to, if we want to do that, if we want to actually create something that's realistic in real-world life application, we somehow have to take that into account.
So I think that's going to come out through the exercises and through your own exercises to think about what you want to do. And the issue of parsimony of a model is certainly something you want to consider. I would just say, though, we don't need to have models that don't require computers, because it turns out that many of us do now have computers.
I just wanted to offer a couple of comments, because I'm also a clinician. I use this clinically every day, and I was stunned when I read this paper. And I feel very sad. Sorry. I just wanted to offer is this on? A couple of comments, because I use this score clinically as well, and I never actually read this paper. It was a little bit, amazed when I read it, but also kind of had to somehow justify why has this persisted. And I guess there's a couple of things that it's not that nobody's interested in this space. There's been a lot of efforts to build subsequent stroke prediction models. This seems to be a very hard thing to predict, and the statistics on all of these models, and I have kind of gone through all of them in detail, but typically range from like 0.55 to 0.7 at best. So you have a very parsimonious model here that hasn't been substantially outperformed by something else, which maybe they also had some parsimony kind of requirements of, right? Because you want to be able to apply these at the bedside. And the second reason I think is that the decision boundary is actually closer to Chad's 2 of 1, right? Once you get 1 or above, you should be, based on that estimated stroke risk, you typically would start somebody on therapeutic anticoagulation. It's when there's no risk factors in there that you might say, well, you can have an aspirin. That seems a reason. So the decision boundary, it's not so much we use the decision boundaries as the score escalates. It's really kind of it's got one particular, for most of its use cases, it's got one boundary of kind of once you get the score of 1 or greater, it doesn't need to be kind of calibrated all the way up. It's escalating kind of great.
And that's part of it, that the outcome is so severe, and that you want to, the risk benefit pushes it way down. So 1 or 2 above that, if you have hypertension or diabetes, okay, you're going on warfarin, because that brings you up to 2. One more person, a question?
I just kind of wanted to respond to what Chris was saying about the complexity of the model and how somebody can, use this chats thing by hand. Is that the more complex? So the more complex machinery doesn't prevent you necessarily from having a simple score. So I very recently read a paper from the Machine Learning and Healthcare Conference from 2016. So they're predicting preterm birth, and they did a lasso regression with a ton of variables. And then at the end, they picked the ones that were most predictive, rounded them to integers, and showed that they got a pretty similar, nice AUC. So it's not always something that you can do or whatever, but that's within the framework. And so you can do all these nice validations and complex models to get the stuff right, and then go back to something that can be handwritten. It's, not really.
Good point. Any other questions before we move into the next section?
Well, it's just one thing on, I think it's similar to the previous comment, but really, even for liver cirrhosis, everyone's still using the Child 2 score that was built in with 6 patients in the 1950s. And there has been the MELD score that was built on machine learning, and the perimeters got a little crazier, but still, despite that we all have computers, I still think there is some room for those kinds of more simpler scores because it just gets more common sense.